Let's go live.
We're live.
Welcome, folks. This is House Corrections and Institutions Committee. It is Thursday, March 12th, and we are back on H550. We have with us Dr. Eulinger from Department of Corrections, who's also with WellPath, who we contract with for providing medical services to our folks who are incarcerated. We are working on draft 1.3 because there is section 6 that deals with the medical care of inmates. And we just want to know just kind of what current practices, and also there's language in terms of administering healthcare services to all inmates in correctional facilities, including transgender, gender diverse, and intersex. So that's new language that would be added, and we just want to know how the world would play out for that. So Dr. Eulinger, welcome. And if you could identify yourself for the record.
Sure. I'm Dr. Jim Eulinger. I'm the statewide medical director for WellPath in the Vermont DOC.
Great. So if you could just kind of give us a broad overview of it, it might be helpful to look at the process in terms of when someone is going through the book and they identify as trans or gender diverse or intersex, what is then the role of WellPath? How does that get referred to you? Is WellPath actually there in booking when something like this, or is the person actually brought to the infirmary? What is the process?
Sure. Well, so as far as I know, we do not have a standardized process. And that's in some ways good and bad. I mean, we see to the medical needs of the person in front of us, no matter what. So much like every situation is different. And it's, while this is a big issue, the number of folks we've dealt with is still rather finite. So I would say each one of their stories is their story. And so whether this comes up during incarceration, whether it comes up at booking, whether it's somebody who's known to us at booking, that, each one of those situations is a little different. I can give a snapshot of I was thinking, and again, my apologies, I've had this for about 18 hours, which is fine, but kind of where we are, where I expect us to be, and kind of where we could go, and then some nice things and maybe some pitfalls in the language that I see, if that's okay with the committee. Where we are, so we expect everybody to take care of. So, and I would ask. There's kind of 2 or 3 aspects of this. Is how do we take care of the person, whatever their gender expression or gender identity, the medical care of their body parts, whatever your identity. If you have a cervix, how do we take care of your cervix? And that is a good example because our DOC health and wellness colleagues, I think about 6 months ago, made sure that they said, do you have the ability to do a pap smear at all of the facilities? And it was a good question. I said, good question. Let's figure that out. And we went all around. We made sure we had both the equipment and the expertise to do it at all facilities, and we do. So that's a good example of the provision of medical care. Then there's the affirming piece, right? And so we do expect people to use their medical providers should be, and this gets to the cultural competence piece, should know how to use proper pronouns. They should know how to, we all make mistakes, how to apologize. Many of the things that the testimony from a month or so ago, that individual was identifying, right? Now, are we executing on that perfectly? No. We did just have a gender affirming care training that was delivered about 2 weeks ago that was required for all medical staff. So that aspect. The third aspect is the gender affirming care piece. And in terms of hormones and surgery. So there's, currently, to qualify, and there's some, and this is relative to some of the language in the bill. The first step is getting a diagnosis of gender dysphoria. And I know that's a sensitive thing because is this a pathological thing or is it just who you are? And I get it. for medical decision-making reasons, particularly if there's an irreversible surgical procedure. The first step is to meet with mental health to have that diagnosis of gender dysphoria. I see that the bill refers to, and I'm looking at page 12 under 3C. And it says affirming medical care, including mental health care related to gender dysphoria or a gender affirmation. So the way I perceive that's a little bit of a broadening. Like, suppose we've determined, that we don't have a firm diagnosis yet of gender dysphoria, but we still, want to affirm people's pronouns or whatever. Do I have that right?
Yeah.
Yeah. And so there's a little bit of, and that particular goal seems, to make sense to me. I think one of the things that I see both our clinicians doing on a kind of one-to-one scale, but also us as a group of clinicians trying to do is to make sure we're affirming gender while avoiding some of the concerning things that could happen. And some of these are theoretical, some of them are not. They're very specific things that have come up. For example, a pretty fundamental one that our PRIA director, I forget her name, brought up at the last time is like, well, okay, I am a trans female. I want access to menstrual supplies. And she made it pretty clear, like, look, you're not menstruating, so we don't give those supplies to cis women who are menstruating, right? So there's some, so is that, so that seems like a pretty straightforward. There's been a case not a case, but a situation. There were, under the previous contract, there were some people getting facial electrolysis for hair removal, for permanent hair removal. And we've been advised that we can't continue that. One, practically we can't continue because we can't find somebody to do it, interestingly, despite a lot of work. But that situation aside, because our contract asks us to follow Medicaid guidelines, and Medicaid does not provide facial electrolysis for gender affirming care, the DOC's legal counsel has interpreted that as we cannot offer that. So one of the things I would like to avoid, and maybe, and I'm not, this is, I'm going to step out of I'm going to stay in my clinical role, but talk about things that aren't entirely clinical. If the intention is to push the language of our contract, so we could be proactive and offer that, fair enough. But the thing I would try to avoid as medical director over the clinicians I supervise is to not have them stuck between a rock and a hard place, where we have language that would require them potentially, depending on the interpretation, to provide a referral to facial electrolysis versus a legal opinion based on our contract that says we can't. And most of the time I see people like, look, I'm happy. I want to take care of the person in front of me. Just tell me what I'm allowed to do. Like, what, like, and that's where, that's one of the challenges. So in that language of, okay, we want to be gender affirming, what are the boundaries around that? And I think so we talked about like menstrual products, facial electrolysis, and then I'll give a third example, which is more, so suppose somebody has been, it's regarding more permanent surgical treatment. So, and I'll try and be as vague as I can while being specific. So we've had issues where people who have some clear paraphilia, which is why they're incarcerated, because of some actions they took related to that, are looking for what they might consider affirmation that is concerning based on the nature of the affirmation they're asking for and the nature of their victims. And I'm not saying what's right or wrong there or whatever, but I'm trying, and we've actually had an expert from, it's very difficult to find folks who are expert in paraphilias and gender affirming care in the carceral setting. Like, that's a very niche thing. And we actually, cost a fair bit of money then, and well spent, honestly, because to get an opinion from a national expert in the opinion on a specific case. So that I want to make sure we have some boundaries that we can provide all the support for the person who's the individual who testified for beginning of February. That person should really have her care really taken care of. And I want to make sure we have the protections for our clinicians that they're not stuck in this place where they feel like they either A, have to do something that's not very good for the person or the community potentially, or that they're stuck with like two directives saying that they have to go this way or that way. And so that's where I'm kind of landing. I'm happy for questions or disagreement, or I'm not pretending like I have all the answers. That's just kind of the world we're living in.
Well, this is very helpful. Thank you. We do have a question here, Troy.
Yeah, incredibly helpful. Thank you, Doctor. One of the things I want to make sure we do right is to include the discretion that we've included with housing placement, with searches that give the department, or now in this case, WellPath, the ability to say, based on, objective evidence, we're going to hold off on fulfilling that request, right? And I think that's paramount when you bring paraphilia into the conversation. And even the journey of gender dysphoria, even once diagnosed, is a longer journey than I think most people realize before we start talking about surgery. All of that. So I agree with you, and it is absolutely my intent to have those safeguards in place so that this truly remains a medical decision on an individualized basis. So yes. That being said, can you do you have a good sense off the top of your head about what Medicaid would cover for in and around gender affirming care? And let's even go as far as even once somebody's been, adequately diagnosed as needing some of the more significant care.
Yeah, I don't have a thorough understanding of the Medicaid guidelines, though. And Dr. Rappaport is the CMO at Medicaid who I've been communicating with about the issues, and that's who would, have that understanding. The reason I know about the electrolysis is I communicated with him directly about that, and he was very unambiguous. My understanding is that it does cover hormones. And gender affirming surgery, that there's some boundaries around that. I can't speak with any authority about what those are.
But it does cover hormones.
As far as I know, yes.
Mm-hmm. So with Medicaid, it appears as if Medicaid is really the driver here in some ways, in terms of what medical care is allowed or not. Does the 1115 waiver play into this at all?
Mm-hmm.
And if is there any way of jeopardizing that waiver by offering care to folks who, I'm just going to use the broad terms so I don't screw up, who are trans in one way or another? Is there any potential that we could jeopardize that waiver?
Yeah, so I'm gonna. That's a great question, a big one, and I'll give you again my understanding of the 1115 language is that we need to offer. And I read this very carefully. Mostly, again, I'm a board certified addiction specialist, so I read it in the language of addiction, sort of language that I'm paraphrasing liberally, but it says that we have to offer everything that our state Medicaid would offer, but it's in class or in kind or something like that. So I was looking like, okay, and for example, so I want to offer long-acting injectable buprenorphine, and it looks like, potentially could we use this? Yes, but did we have to as a requirement to start the program? And my recollection when I looked at that was no, because we offered that class or kind of therapy. So I understand it. I'm not aware of anything that will allow us to be more generous than what our Medicaid. I don't know that that would jeopardize the 1115 waiver if we have benefits that Medicaid does not include. And I think that's this is not theoretical, it's uncommon, but I have had people say, oh, I've been locked up so I could get insurance or I could get this benefit. And I'm using the language the person used. So I think we should be thoughtful about offering benefits that are richer than the community benefit. But I'm not saying it's incorrect. In speaking with our DOC colleagues in health and wellness, we talked about this specifically, that would this be nice if we could offer electrolysis? And we kind of both thought like, well, yeah, absolutely might be nice. I just don't want people wedged in, but I don't think there's a danger of a richer benefit negating the 1115 waiver.
So Doctor, I'm looking at just kind of what we talked about yesterday. And one of the questions I have in terms of the language we currently have in the bill is that the Department of DOC would ensure that department staff, contractors receive gender responsive training. So WellPath is one of the contractors. So currently, is that occurring, that the department's ensuring that your folks are receiving gender responsive training?
Yes.
And how are they doing that, and how often does that occur?
So, well, there's like anything, there's a formal and an informal curriculum. So WellPath does now have a formal curriculum. We rolled it out in our contract, and it took a lot longer. We've been trying to do it since September. We just had everybody do it in the last 2 weeks. What we'd like to do, and I'm not sure where it stands, is put it, like everything in healthcare, there's a set of annual trainings you have to do on where the fire extinguisher is, annual CPR things. And this would just go right there. We would just treat that like everything else. There are some logistical barriers to putting that in there today, but I know that that's the goal. So, and that would be, and this is kind of nice. My understanding is that would be nationwide. So we would, Vermont would be helping drive our care and other contracts, which is a lovely thing. Mm-hmm. And then there's the informal curriculum, right? Like how do we, for example, in our provider meetings, I really try and have a safe space. Like, hey, these are, some people get the whole gender affirming care process. Some people, they're still trying to get their heads around it, right? And so I try and offer a safe space where we can have those conversations and people can ask questions. So there's an informal and formal curriculum, and it's required.
It's required.
Yes.
So the next question I have is, when a person comes through, it's both the intake process as well as maybe they've been in the facility for a while, like maybe a year or two. They could be a detainee, they could be sentenced, and they're really finding that their gender, they're identifying differently. And DOC has to look at the classification housing placement for that individual. And the language that we have, and we had testimony yesterday from DOC, that there is a review panel that that DOC has. And in the language in the bill, it's called multidisciplinary review panel. And in the bill, it would be composed of medical personnel, mental health personnel with experience in gender dysphoria. I can't pronounce that word. Dysphoria and gender affirming care, and personnel who have received training aligned with nationally recognized standards for gender affirming care. Is that currently happening? Do you know that DOC, the department, is reaching out to a panel such as this currently to help make decisions on the classification and the housing placement?
We do not have a somatic provider, meaning non-mental health provider, that's consulted as far as I know. I'm going to ask, if I may, ask one of my colleagues who is a really fast response on Teams, if we have that weighed in on from a mental health standpoint. So I
Yeah,
will.
because, so do you have a panel right now that you're part of, the WellPath is part of? I don't want to get into the specifics of what the language says right now. Is there a panel right now or an ad hoc group or something right now that the department, like at booking, or if a person's been there for a while,
So not
classify and
right.
place the person in a housing unit?
So I unless it's our mental health group, which is not under me, we are not a direct part of that group. And I have some mixed feelings about that. Not because it wouldn't be great to have somebody's expertise there. It's because how much we weigh into security matters could create a conflict of interest. And so forgive me, I'm thinking out loud here. It could be totally appropriate to have somebody on that committee. I'd have to chew on that for a minute. So no, as far as I know, we don't have anybody on the medical non-behavioral health side that's part of the housing decision, though we are consulted. And I'm asking Dr. Richards, who's our psychiatrist right now.
Yeah, so we have language in the bill that would have a multidisciplinary review panel that would include, it shall be composed of individuals, including medical personnel, mental health personnel with experience, and personnel who have received training aligned with nationally recognized standards of gender affirming care.
Your psychiatrist would be considered medical personnel though, right?
Well,
Scope
yes.
of practice. Is it scope of practice though?
Yeah.
Well, medical, there's the rich question that's been a problem in America for years. Oh, Allison says yes. Dr. Richards says yes. So
Yes to what?
yes, here we go. Is mental health part of the housing panel for folks, for gender diverse folks in choosing? Okay, Colleen is on it, but Colleen is there a WellPath clinician? So what I'm learning is that Colleen's our director of mental health on the DOC side, not part of the WellPath contract. And she would fit all of those things. She's just not a WellPath. And that's how we could avoid the potential conflict of interest, because Colleen does not provide direct care. And Dr. Richards is saying there's not a WellPath clinician on that committee, but it's Colleen.
But there is a DOC person that has medical.
There is a DOC person who's, and forgive me, I don't know what Colleen's exact credential is, but she's a therapist of some level of training. And Colleen, if you're hearing this, forgive me, I should know what your credentials are.
Can you say a little bit more about what that conflict of interest, how that would present?
We got to do some work.
Well, okay, suppose, and I'm gonna, this could play out in positive and negative scenarios. So I'm just gonna make one that's purposely negative. Suppose I was your doctor and I got to be a part of a group that decided whether you're going to go to the place you wanted to live or not. And that group decided no. And then you had to come see me and we talked about your whatever, the pimple on your knee or whatever. You know, that's kind of a rough relationship to have. I'm not saying it's incorrect. I'm just, again, it's new information.
Well, no, but the one thing I wanted to ask then is just for maybe for all of us. So does that mean, so when they're talking about the most multidisciplinary review panel here, are they referring to WellPath? And are they also referring to that woman that he was just talking about? Is that who that group is? And is that okay? That's my question, I guess.
I mean, the current structure.
Yeah.
That's happening now.
Yeah, is that do you understand that, Troy? And is that all good?
Yeah, but I have an understanding that Dr. Richards has been part of these conversations.
She has been, but she's not on the committee that makes the decision.
So she's consulted.
That's correct. So here's what she replied. I think it would not be appropriate for us to be involved in that level. but she put a question mark. She's thinking about it just like I am, right? Like,
Right.
and
Got
and
it.
then
Well,
and then
But
she said, "We are
consultative,
not
okay.
involved in their PREA investigations or disciplinary actions, which is part of housing." And I'm just, this is as rich as text can be. I know this isn't really a disciplinary thing, but we are talking about safety. Are people safe? Is this person
Yeah.
safe? Are people safe?
so the language doesn't indicate where the mental health personnel is coming from.
Right.
And I don't know where it is in the draft that you've got, because we have a different draft that I'm reading off of. It would,
1.3, it's on page 9.
yeah, it's on page 9,
But can
number
we,
2.
but if that language just said in consultation with medical personnel, that the multidisciplinary review panel is in regular consultation with medical personnel, that would not trigger that conflict, right?
Absolutely. I think that makes so much sense because what I would imagine, and I could be educated on this clearly, but what would I offer to that committee? I could offer what the person's anatomy is. I like it. We're not supposed to do kind of forensic genital examinations. That makes total sense, right? Here's what their anatomy is. Here's what their sexual function could be in terms of safety. Here's what their process in where we are in terms of their transition. What that all could be helpful. That the person doesn't have to have a vote though.
Right.
So we might want to think about that with Hillary with our next draft.
Yeah, I don't think this is insurmountable.
Right. That's why this medical care, when we looked at this section, it just said to me, we're gonna have to do a lot more work on this. So what we may end up doing, Dr. Uliger, is just put in some language as placeholder, because we're under a deadline to get the bill out tomorrow. And then once our schedule opens up a little bit here in the committee after that, once the bill is in the Senate, this committee can do more work on the medical care piece and then offer that as the bill progresses through the process. So another question that I have is if you go back, it's dealing with the searches, which would, I think it's section 4. And it says the department, currently what the bill is saying, the department would not search, physically examine any individual for the sole purpose of determining the individual's genital status. If the individual's genital status is unknown, it may be determined during conversations with the individual by reviewing medical records, or if necessary, by learning the information as part of a broader medical examination conducted in private by a healthcare practitioner.
Mm-hmm.
So is that current practice that's happening, or is this going to be new practice, and is it possible on well past end?
Yeah, I can speak to the medical part. I can't speak to what security does.
Right.
But it is not current practice to do, we only do any sensitive exam if we really have to, for a variety of reasons and the trauma people have been through and whatnot. So the challenge here would be this, it makes it sound almost incidental that would be like, oh, we did an exam and yes, we noticed X, Y, and Z. The problem is we don't do that incidental exam on most people. Not only everyone, but most people we don't, for specific reasons. So I do think if that were a question, and records can be incomplete, so records, it's totally appropriate to have examination records, etc. Like, if we have a surgical record that says the uterus was removed, then the uterus was removed, right? We're not going to do some. But if we, the other concern reading this would be there are people who are dangerous that we wouldn't want to do a sensitive exam without some sort of security present. And in those circumstances, we do everything we can to make it as private as possible. But that's...
Wonder if it's private could be interpreted that there is a private space away from living units, away from where other inmates are, that it's private as much as it can be within the infirmary or the healthcare arena.
Yeah. And that's so, and you know, our infrastructure, this whole committee does, it's the privacy is a giant issue. Maybe if I could suggest something that it is done with in a setting private with a privacy commensurate with a sensitive medical exams or something like this is how we do sensitive medical exams.
The way I interpret private setting is it's in a private room. It's a room that is separate from the flow of the facility. It's not talking about one person being there with the inmate. It's the setting is private from the rest of the building.
So
that's how I'm interpreting.
And that makes sense. In some places, we don't have that room.
In the infirmary or in the building itself?
In the building itself. And infirmary, if you mean in like the medical suite.
Right.
We don't always have a place to do that. A place with a door. We have a curtain. We always have a door. We might have to have a security person. In most cases, we don't. But in certain cases, we have to have a security person in the room with us while we're doing that exam. And in reading this a little bit, it would give me some like, okay, is that security person allowed to be here or not? And we do everything we can not to have that person there, by the way.
So if there's to be a search done of a person.
We don't do forensic searches, just to be clear.
It's just the DOC staff that would do it, and they wouldn't consult with the medical at all, or vice versa.
We won't. This came up with drug stuffing and packing.
Oh, okay.
We will not look for things in people for forensic reason.
Okay, sure.
So specific to this section, so page 6, line 16 is where the section begins. I'm at the end of the section, so lines 20 and 21. This is the purpose of this section is just to say that the department shall not search or physically examine for the sole purposes of determining an individual's general status. And then it talks about if that information is gleaned from other processes that have already occurred.
Like medical records.
So you can just take in private out there, right? Part of a broader medical examination conducted by a health care practitioner, regardless of whether or not they conducted that in private or not, doesn't matter.
Sure.
This is where the information comes from that could provide information that has not been gathered through what we're calling an inappropriate search, which is to determine genital status.
Sure.
We can strike in private there and be done with this part of it. Because
and it's the in private. The way I read that, and maybe I was reading it incorrectly.
Yeah.
Examination conducted in private, that means secure. To me, that means security is not allowed to be there.
Yeah, we can take that. We can just say conducted by a healthcare practitioner.
Right, so then
We're referring to something that has already happened.
Right, and the way we interpret private is a private room or setting.
Right.
But that could be interpreted differently.
It could
Just
be.
we can take in private out of
To provide the committee reassurance, if somebody was called to booking in a public area and asked to examine a disrobed patient, I would fully expect that provider to be like, I'm absolutely not doing that. So that's, just to be clear, that shouldn't be a thing.
So, doctor, when you're looking at medical records, and I know we've, in this committee, have looked a lot over the years in terms of what comes in with an inmate in terms of their medical records and their prescriptions that they have, and who their medical provider is or not, who their pharmacy is or not. And for folks who gender identify differently, is there a tendency for them to have more of their medical records with them or available from that they have a primary care provider? Because many folks who are coming into the incarcerative setting do not have a primary care provider. They'll tell you they do. And once DOC and WellPath Medical starts looking into this to get some of the records, they don't. And the same with prescription. They'll say they have prescriptions for certain medication. And yeah, they may have had a year ago, but they never picked it up. Are you running into something different with folks who identify differently with their gender?
Not that I'm aware of, and I'm not sure our sample size is large enough to determine, a correlation there. But no, not that I'm aware of, that we would have some different.
But are you having access to their medical records out in the community?
It's really variable. And I'm pleased to the degree to which we can get access. Actually,
Yeah.
this is, and it's more of an issue with people who come from out of state, or who are in state who've had out of state care. Vital has been fantastic. So if you're doing transitional care with a primary care provider in the state and your records are on Vital, like there we are. That's not a problem.
Kevin?
Can I ask with your experience with Vermont DOC, what is your sample size? Roughly how many individuals have you dealt with this challenge?
I can speak to the active cases, which I think are single digits, but let me ask Dr. Richards. Care spreadsheet.
And I would assume of this very small number, these individuals would come to you or would be involved with you because they're looking for assistance. They're not trying to hide their status. So although security is always critical, I wouldn't think that there should be resistance to examination to understand from a medical perspective what the reality is.
Yeah, I think that's going to be very patient specific. So think of trauma people have been through. There's also some trauma even about what you call, I've run into this when I was first trying to understand folks who are experiencing this whole situation. What was hard to me, somebody said, well, you can't call them testicles. And I'm like, I know, but I'm trying to, you have a lump. I'm trying to make sure you don't have testicular cancer. And I'm trying to be sensitive to the person, but I'm trying to call it what it is. And so this is like where it's a while ago when I was like kind of on my journey, getting my head around all this. And so the reason I'm sharing that is that the way it is with one person is kind of the way it is with one person. Does that make sense? And I do think we would do everything in our power if we're like, look, we're trying to get you housed at wherever Chittenden say, we need some clarification on what's there. Can we collaborate on this? That's the way we would do it. I would hate for it to become something that was traumatic or difficult for either patient or provider for that matter.
Right. And I guess that's what I'm trying to say. I don't see this as needing to be an adversarial situation, because if they're choosing to identify differently than the norm, I guess it's the only way I can say it, they should be willing to share whatever they know to get the assistance they want.
Possibly. I guess here's a situation, and this is a little, I'll speak to my medical piece and just put so what if somebody says, I want to be at Chittenden and it's not clear what their genital status is and they refuse to submit to an exam. So does this law weigh into that or not? Because they have the right to refuse medical care, right? Because
everyone has the right.
What this section is saying that we're in those instances, we're not going to do a search for the sole purpose of determining the individual genital status. And I think that's an important protection, right? Because if everybody's identity journey is different, including for those who identify as gender diverse, transgender, and we're not even talking about intersex folks here, right? And that's part of this too. So again, if I am identifying as a trans woman and we're having that conversation with DOC, this policy, this bill currently has outs, I'll call them, for the department to hit the pause button and to say, let's have a more detailed conversation here. That more detailed conversation is not going to include a search so that we can talk about your genitals as part of that conversation. I think that is an incredibly important protection here. Now, this section of the bill, does allow the Department of Corrections to access medical records that may already exist.
But WellPath does not do a search.
They may have in the past, then they haven't done a search, but they've
They've
done an
done a physical.
examination, and that might be in their medical records, right?
It'd be a physical,
Right.
but it
So-
won't be a search.
This is, all this section is doing is saying, we're not gonna search you as we determine whether or not you really are trans enough. That's what this section is doing.
DOC,
Right.
the department,
Yeah.
not WellPath.
This section of the bill doesn't bring WellPath into it.
Right.
Aside from the fact that WellPath might have some records existing.
Right.
So the clarity I would ask for would be that if DOC comes to us and says, we're trying to make and I think I know the answer
Right.
based on what you're saying. We're trying to make a safe determination about this person's housing. Can you please do an exam to confirm X, Y, or Z? It sounds like we're supposed to say no.
Well,
I know the answer, but there are occasions where a physical search is required, yes?
yes, but WellPath does not do.
Understand that.
And not for determining identity.
And not for-
I understand. But if there are those situations, you can't help but have an examination.
So we don't do forensic examinations.
Right.
I understand that.
So you would say no in those instances.
So we would have to say
Right.
no.
Yeah.
And I just want, the thing I would ask for is clarity. Just real clarity on that.
Say that again, you'd ask for what?
Clarity in the bill.
Clarity.
Yeah.
And I think I now that I think through it, maybe the bill, I see what you're saying. Yeah, the bill does that, but it didn't come out at me. I would
Gotcha.
ask for it to be very clear about that.
Okay.
Not that we couldn't do an exam for a medical indication. And we're used to this. Like, what are we really doing here? Are we trying to help you with your medical problem, or are we determining some piece of evidence? And
Right, exactly.
Right.
and we if the bill could be even a little clearer about that, I think that would be really helpful.
And so that would be in what section of the bill, Troy? Would that be in the gender identification and discriminate?
What are you asking? That the clarity that he's asking for?
Would that be in the searches?
I think it can belong,
All of it?
yeah, I think.
Classification,
I would probably want Hillary's thoughts on this, but I think it's certainly, I think we can clarify section 4B to bring some of this in, that department shall not ask medical contractor to do any sort of forensic searching outside of normal medical.
Including.
Yeah,
That's what I would say, including.
right.
So when a physical search is necessary, we prefer having a non-doctor
That's not
performing
what we're
that.
saying, Council.
Well, that's what I'm asking. What are we saying? Who's gonna do it if it's not gonna be a medical person?
We're saying nobody's gonna do a search to determine a genital status as we're talking about gender identity.
So we literally want to be blind to physical data.
That's not what we're saying.
I don't think that's true. Because we are allowing here, and maybe I'm missing the boat too, so tell me, but you are allowed to learn that information as part of a larger medical exam. And so I would think that DOC, if you're in one of these fringe cases, is going to say, we need to pause and let's perhaps have this be a part of that process. Would that be acceptable? It's not to determine genital status. We have to know about this properly.
Yeah. Right, let's look at what information we have.
So in a way, and if we need to make it clearer, let's make it clearer, but I think the answer is contained within 20 and 21.
I agree with you.
And maybe we need to explicate, right? But
Yeah.
What do you mean within 20 and 21?
I'm sorry, lines 20 and 21 on page 6, the very bottom of 6 that we were already talking
And
about.
you're on 2.1?
I think so.
Yes.
Actually, no, I'm sorry, I'm on 1.3.
1.3.
But yeah, a broader medical examination conducted in private by a healthcare practitioner.
What page are you on 1.3?
1.3, I'm at the bottom of page 6, lines 20 and 21. which is
Okay.
part of 4B that we've been talking about.
Yeah,
So that's dealing with searches.
Except this is not a search here. This is learning the information as part of a broader medical examination.
because we're not searching.
Right, but you're in the searches section.
Yes, we are.
Yeah.
If it's okay with the committee, I just need to step away for a moment. My apologies.
Yeah,
Take the time anyway.
The language here in B, from what I had from yesterday's, or one testimony I had from Hillary, this language was taken from the federal PREA language in B.
Yeah.
And what I've heard, what we're proposing right now is to take out on lines 21, conducted in private.
Saying it doesn't matter.
I don't think that
I'm
matters.
saying it doesn't matter now.
It's conducted by a.
I don't know if it helps anybody else. For me, it's useful to reground occasionally that we're not going to be idiots and go blind and you know, just, you know, trust. Okay. But at the basis of this legislation or proposed legislation is respect. And so how do we do both?
Right.
Yeah, I don't want to let one trump the other. I don't want to be a moron about it, but you know.
And I think Dr. Uliger is asking for clarity in this section beyond striking in private, that they're not going to be asked to do the search that we're saying is not, that PREA is saying is not lawful.
And I think DOC has indicated before that if there is a question, they're going to pause, they're going to tread water until
Yeah.
they can sort it out. It's not let's blindly go ahead without having figured out what's going on.
They would also have access to reviewing medical records. So if the person had had a physical at this point, that's part of their medical record.
Yes.
Well, maybe that point is about to happen. Maybe they're about to have a physical exam broadly for their health in which this could be determined not as a search.
Right.
And I don't want to split hairs, like I'm not trying to get cute, but
So we're not in people's genitals very often.
We're not what?
We're not examining people's genitals very often.
Right.
And I'll give you an example. The 1115 waiver, there's a requirement that we have to do a disrobed exam for youth under 21 and foster care graduates under 26. And I fought tooth and nail to get language in there that was like, if clinically appropriate or something, because most of the time there isn't a good reason to do one. And the risk of sexual trauma in those individuals is so high that unless we have a reason to, we just don't.
What's the second category?
so I guess for clarification then, within the context of this bill and within the context of DOC, what is a broader or broad medical exam? Does that mean anything to you?
A broader, well, so if we had to do an exam for an indication, somebody says, "Hey, I have a discharge." Well, we do an exam.
Huh.
So it's just a different reason. It's not a descriptor of the kinds of things that might go into it.
Yes, and I'm just trying. I guess what I'm trying to say is I don't want the committee to have the impression that we do an unclothed exam on everybody. It's
Right.
actually a minority of folks. I
Right.
do think if it helps at all, I think if this question, if there was a reason we needed to know the genital status of somebody, we could have some sort of medical way of obtaining that information the way the bill is written. I think that we could, you know, if they had some surgical treatment, we could get the surgical records. If so, I don't think that's.
And that goes back to my question about having access to their medical records out in the community. That was my question, because folks are coming in and if they are quite a ways along in their transition and they did have surgery, that will be part of a medical record in the community that you would have access to if they allowed it. Again,
would
it's
be- Yes. And I mean, this is not a medical thing, but if that's what you're asking for, then gosh, you have to, you know, that seems like a reasonable ask, but that's outside of medical. It would be unlikely that somebody had that level of a surgery there's only so many centers in the country that are doing that.
Right.
So we should be able, it would be difficult to imagine, maybe if it was done out of the country, that would be one. If it was done somewhere else, that could be a situation where it'd be challenging.
But you would have access, DOC, WellPath would have access to those medical records out in the community in terms of what the person has availed themselves of medically in their transition.
Yes.
And that would then be incorporated in the WellPath medical records for that individual.
Yes. And there are barriers to getting records like that, but yes. Barriers notwithstanding.
Right. So we need to work with Hillary on more clarity in this section is what I'm picking up.
I don't think it's gonna take much.
Okay.
Well, the language is important, but is there any part of this that we're still unclear about that requires, and I'm asking, DOC, Priya, Josh, and Jen, as opposed to Dr. Eulig or WellPath? You know, what if DOC hits a snag?
Right, well, that's why we got more work on the bill.
But yeah, I don't think there's anything further on this part of this that I can learn from Dr. Euliger.
And DOC is gonna be in the room this afternoon, we hope.
Yeah.
And
I'm legitimately asking if we need anything beyond the first sentence of section B.
you mean, of section B,
Yeah.
Department shall not search or physically examine any individual for the sole purposes of determining the individual's genitalia status,
Period.
period.
So I'll leave, for the whole section B, that's all you would put in
Yeah.
there. So I'll leave just, it didn't hit me. It's very clear that we don't collect evidence when we do any sort of exam. It didn't hit me until the rich discussion that this is evidence. Like that took me a minute to get my head around. So I guess I would leave you with that and let you guys decide how much, what you need or not. But it took me a minute to.
Well, and so, I mean, it sounds like that's like a guiding star, if not the guiding star, but suppose we were to cut down this section to just that first sentence, does that put you, the medical provider, or WellPath in an awkward position? Is there a case in which DOC is like, hey, we need to know this? You know, does that set up confrontation or conflict between you and them?
It doesn't set up, it's to me, it sets up a bit of a mistake. It sets up like the department shall not search, but medical can't. Like, okay, we'll do that for you. And then afterwards being like, wait a minute, oh my, we can't do that.
So,
Even
and
with
shall
the
not
business
ask a medical contractor to do a forensic.
Yeah.
Yeah.
Well, and I would, and that's well known, I guess, that this is a forensic thing. And maybe that's just me. Maybe if this is enough, I'll leave that to the attorneys and whatnot, and we'll just educate our provider. If that's what we need to do, we'll just educate. That could be part of education instead of the bill. That's fine. But.
Wouldn't we want to know if an individual presents with a cancerous growth rather than a unique genitalia? And I mean, in those very, very rare situations, why wouldn't we want a medical doctor being the one who's determining the physical status of an individual?
I think we have to be really clear when we're talking about searches.
I know, I'm being very specific, and that's where I thought on page 6, line 5, we were going to add the words, the department shall not overrule solely on an individual's search. Because they may have a unique situation, but they truly, that's not enough to say that they're a harm to themselves or to others. And so we don't want to solely determine it on that, but we don't want to go in blindly because.
But the search, this language under DOC, we're talking about a forensic search.
Right.
We're not talking about medical searches. We're talking about a search to see if they're bringing in contraband.
Right.
That type. If during that forensic search, Dr. Euliger, there is an indication there could be a growth on their bodies somewhere that could be like, this could be malignant, this could be cancer, something. would DOC staff, if they saw something like this in their regular search for safety of the facility and security of the facility, if they found something like this on a person's body that triggered, that they thought this really needs medical to look at, would they make a referral to the infirmary?
They typically do, yeah.
Okay. Okay. So that would answer your question, Kevin.
I just wanted to make sure I understood the question. So are you asking for an addition to or a change to the language in 5 and 6? You said solely, but what's the?
No, my notes indicated that we were going to add the words solely on an individual search classification.
That was non-discrimination.
Well, that's maybe, yeah.
That was the
Is that correct? Yes.
that didn't deal with the search. That was the non-discrimination.
Yes,
The
but
department's
we wouldn't make a
decision,
decision solely on the anatomy.
right,
And what I'm saying is, if the anatomy isn't understood from a medical standpoint, trying to make a decision in the absence of our data.
But I think this is almost the exact opposite of that. It's saying an individual expresses a preference for a search and you know their genital status and you cannot overrule their choice about how to be searched based on what you know. And you already know it in this case. That's not to be determined.
I don't agree with the point. I understand what we're trying to do in the language here. We don't want that, the genital to be the single reason we choose not to house an individual where they want to be housed or treated.
Yeah, totally agree. I'm just trying to understand the objection. But here, I don't think the solely would change that. Here, we're already saying, you already know what's going on with this particular individual in our hypothetical case. You know what's downstairs, but you can't make a decision based solely on that if they have expressed a different preference.
But if a physical search is necessary, I'd rather have a medical person doing it than a non-medical person because they know what they're looking at.
But irrelevant here because you already know.
Okay, fine.
I would just want our providers only to be, if they're doing a sensitive exam or any exam for that matter, it's to diagnose, treat, or prevent a disease.
Yeah. And that was, yeah, I guess that was the other thing is I'm going to rely on DOC people to tell me about safety and risk and threat and all that stuff. And that's not to say this isn't relevant.
But in doctor's experience, he examined and had to convince the patient that what he was seeing is different than what they thought they were seeing, is what I was hearing.
It was just being
So
sensitive around the
if he has
language.
to convince, the DOC isn't going to be in a position to convince the person that there needs to be further. I need to have horse. I'll stop. Thank you.
No, I was just trying to be crystal. Yeah, not
No, I
trying to be, yeah.
so we're gonna have conversations with Hillary on this, and I might recommend that Hillary take a look at this YouTube, just to understand the scope of the conversation that we had. This pertains to searches. And then there's also a section, what Kevin brought up was the non-discrimination. That DOC could not overrule a person's search, classification, housing, or program placement request based on their anatomy. Solely on their anatomy.
That was in yesterday's.
That's in yesterday's draft.
Right.
I'm looking to see, then there needs to be some clarity on the classification, housing, and program placement section. And in terms of those multidisciplinary review panel, that they would in consultation. Just wondering where else in the current language that we're looking at that would tie in WellPath when we have WellPath in the room.
Well, I think you could go through all of section 7. Which is all WellPath,
Yeah, we didn't.
or section 6, I'm sorry.
Which one are you on? Draft
On
1.3.
1.3, page 11, section 6, not section 7.
For the proposed language there, on the top of page 12, on draft 1.3. Again, to the extent feasible means as best you can. That's flexible language in legalese. DOC and WellPath shall ensure the use of licensed healthcare providers with cultural competency to administer services to all inmates. How do you define cultural competency? Is that part of your world at this point in terms of your licensed healthcare providers?
Is that a question for me?
Yes.
Yeah, fix that.
Fix that, right.
Yeah. So I think, as I mentioned last time, cultural competency is specific to the culture. So you could be culturally competent in one culture, but not another.
Which is-
But I think that's also maybe a little bit academic. Like when I read this, and especially with it's with the softening of to the extent possible, right? I kind of get what the intent is here. So we could wordsmith this till the
Cows come home.
days.
Right.
Okay.
Yeah, I kind of get it.
We have it defined in statute. We have it defined.
Is that in our definition?
Yeah.
No. Is
And
it?
it's related
It's
to,
in current
it's
statute.
related to 18 BSA 251. I've already sent it to Tate in case we want to print it up.
Okay.
I anticipated it's getting here.
So then this section goes on, Doctor, to say the contractor would ensure the inmates' access to all necessary and appropriate medical and mental health care, routine and preventive medical care to an inmate's sex characteristics, and affirming medical care, including mental health care, as related to gender dysphoria or gender affirmation. So that's current language. At this point, I know we're not going to stay with this, but when we revisit this later on in a few weeks, this will be our starting point. So you may not be able to weigh in on it as much today, but in a couple of weeks, we'll have you back to really weigh in on this. Does that make sense?
I'm comfortable with that. Yeah.
And then we come into screening and assessments. That when a person is coming into a facility and within 14 days, and I'm assuming this would be, I'm not sure if this includes 15 days or not, the new language on B and C. The physical assessment would identify any medical needs, mental health needs related to gender affirming care. Are you able to do that now? Do you do that now?
Can you tell me which page and line you're on? I'm sorry.
Page 12, lines 16 and 17. That's under screening and assessments.
Is he looking at 1.3?
1.3, yeah. That's screening and assessment. That would be, I'm assuming that would be when folks are coming into the facility, though it's not really clear if it's within that 14-day window.
Yeah, the way I read that is that we would, gosh, this is a person in our men's facility with a uterus, and we're going to have to make sure that we have on our mind screening for cervical cancer. That's how I got that. If it means, well, this person is on 0.4 milligrams of estrogen and they want to be on 0.6, and we have to make sure we do that today or else we're violating that. That doesn't, and I don't think it's the latter. And it could be, not that we wouldn't do that, but I'm just saying, like, you know, you kind of have to triage what you're dealing with there. And so I review that as like, you should know who you're taking care of and what they need. The only other thing I would add to that, and I don't see this as, it doesn't concern me, but I don't write bills for a living. you know, people reveal what they're revealed to when they're ready. So I don't want our clinicians to feel like they have to like hammer all of the details out of everybody because that's what they're required to do. That there's a time and a place when somebody's ready to reveal things to you.
And it may not be when they first enter
Absolutely not.
facility and they're booking.
Right. Right. And so I think I don't have a big problem with this, you know, might be say, you know, within a therapeutic way or something. I don't know, but I don't see this as an issue personally.
Ask a question.
Yep.
At the risk of opening this up again,
Yeah,
Ooh.
it's right there again.
we are, so section 1A that begins on 13 clearly identifies that this is the point in admission to correctional facility where we're gonna initiate a physical assessment. Do we need C here? Because this refers back, it's the same language, it's identical to a departmental search, not a physical assessment.
But Troy, the way this is drafted, I'm wondering, is it a screening and assessment? It's talking about medical care of inmates. And A is provision of medical care. And B is B, 1A pertains to that 14-day minimum.
Yeah.
1B deals with screening and assessments. I'm not sure if it's within that 14
Okay.
days or if the person's been there for a couple of years.
Right, that's fine too.
The way it's laid out is
We
confusing.
can fix that, but my question remains, do we need C here? Because all of a sudden we're talking about departmental searches again.
Again, and if the inmate's genital status is unknown, it may be determined during conversations with the inmate. Well, who has those conversations? Is it DOC staff or the contractor?
I just don't know that we should be talking about searches, departmental searches again, within the context of medical assessments.
I would agree from my own standpoint that to me, I feel like here I could be interpreted as an agent for the department, unless
Right.
that's defined somewhere else.
Yeah, I don't think we need C here,
Right.
repeated here. Problems with C aside, I don't think, even once we get them fixed, it should be here.
Yeah, I agree with that.
That would be it for the medical care. So, Dr. Eulinger, it's been very helpful today because we know with this medical care section, I think where we're headed because there, as I said, some folks are missing a little bit earlier this morning. Hillary, our legal counsel, approached me yesterday after we'd finished work. She had had some conversations with her colleagues in Ledge Council, the two legislative staff folks who work directly with medical and Medicaid, with Committee on Human Services and Committee on Healthcare. They had some concerns about this section of the bill, really wanted to work more in depth with it, but they're just in such a crunch with crossover that what I think we may be doing as committee, people are amenable to this, is just put in some placeholder language so that it allows us time to keep the bill moving. And while the bill is over in the Senate, we can come back to this issue when people have more time and really focus.
So by that, do you mean that we'll propose language and work with them to put it in, or that we'll amend it when it gets back?
We'll have to work with whatever committee this goes to in the Senate, which we're trying to figure that out. But we're gonna have more time after we get out the Capitol bill
Okay.
to really get our head around this and bring in folks to testify, and they're not so busy,
Okay.
and work up language. And then from there, we don't know what the process will be.
And are you saying that sort of generally about the language, or do you mean like this part or a couple?
This part only for the the medical part. So we could put in language such as in terms of how we proceed with medical care for inmates who are in transition. The Joint Justice Oversight Committee needs to look at current practice and come back with recommended language.
Okay.
Just do something like that, so at least there's a section there that deals with medical care. But it doesn't lock in any language. So it's a placeholder. That's called placeholder language. Kevin?
I don't like to use the term again, but I'm still interested in the magnitude, the sample size that you've experienced.
Yeah, it's about, I asked and I put it in the chat. It's about, currently we're following about 11 or 12 folks in our system out of somewhere between 14 and 1600.
Thank you very much.
Again, they're under state custody
Mhm.
for that. We're not, this language too, it's talking more with folks who are incarcerated, but we're also looking at the safety within the facility and the culture within the facility. And as was testified yesterday from DOC, that there are staff members who are transitioning as well. So it's more than just folks who are incarcerated under state custody. It's folks who are our employees, our state employees as well. For that, one thing that we are looking at, Doctor, is we're looking at right now in a version is to codify, put in statute, the PREA standards, Prison Rape Elimination Act. Do you have any thoughts or weigh in at all about PREA in terms of what your world or not? I know that's a little different than what we gave you a heads up on, but
I don't. I don't. But I no. Not off the top of my head.
anything else, Doctor, before we take a break here? I want to thank you, Dr. Eulinger, for really accommodating your time.
Yes.
For us, this is very helpful. It also, what it really did is help us clarify some language in the draft that we've been working on that's not in the medical care section specifically, but in other sections that does pull out the medical provider being involved. And you really helped clarify that for us.
Well, I thank the committee for their patience. And, 10 years ago, this was something we were hardly talking about, and we're trying to all, so thank you for the time is what I'm still trying to get my head around it. And I really appreciate it.
Yeah. Well, we
Join the crew.
all are, but at least the key is we're working in a respectful manner. And we want to ensure that WellPath and your employees, as well as DOC and their employees, are respectful, as well as inmates are respectful. That's the goal.
A good one.
Thank you.
Thank you.
Thank you.
So folks, let's take a break. Back here around 10 o'clock.
Right.
Because John is, no, John.
I mean, John, that's
John's
right, sorry,
coming
John,
in
right. I was
with a
jumping
new
ahead.
draft of the telecommunications bill. And maybe we can have a possible vote, possibly.
When we have time, you want to tell them no. Big.
Oh, yeah. Yeah, you signed off, right?
Yeah. It's a 2-second thing.
Yeah, signed off, yeah.
So the quick version, our big massive committee of conference. The only thing that happened, they agreed with all of our stuff. They only wanted where we had taken out our state lease buildings
For
they
the
want-
inventory,
for the
right?
inventory. They want,
Name a building after Alice.
no.
That's
But-
for your correction.
So I'm just trying to get through so people can have a break. But anyways, they wanted that in, and the reason why they wanted it in is because they wanted to have a list so that they could compare if we're leasing property and then we're at the same time trying to say, well, we have empty space that we own. Should those people in a lease property be in the places we owned? Like, so that was their rationale. And we're like, we're not fighting over this. So that was the only change we made. So that's it.
So the same reason I'm not coming.
Same reason why.
It was,
So right now, they already do that because
Yes.
they figure out, they're looking all the time how much they're paying for leases in a community.
Mhm.
And when that hits a certain level where it would be cheaper to house them in a facility, they're gonna move them to
So-
a state-owned facility or build one.
and so we didn't have a problem with that back in. Sorry for,
That already exists.
but that's all. Thank
Okay,
you.
Love it.
let's take a break and make sure you come back here in a timely manner so we don't keep John